I'm Ronnie Chambers. I've been in practice for 45 years. I'm in the Houston area. So Sophie is a 51-year-old female overweight patient presented to this office with sacroiliac joint pain, related hip pain for a period of months. She reported the sacroiliac joint pain as being a constant dull aching pain on a 5 on a scale of 1 to 10, and so were the other symptoms on a scale of 1 to 10, aching pain in her thigh, hip region. This aching pain adversely affected her ability to function and limited her ability to work as a market consultant, which involves sitting for long periods of time, which most of your patients have. Prone palpation observation revealed left lateral flexion of the occiput. I learned this from Dr. Victor Frank. Otherwise, most people don't even check it. Sensitivity to palpation was also noted between the shoulder blades. Prone leg length assessment tested revealed uneven leg length, with the left appearing shorter than the right. So this is the left posterior ilium. Standing muscle testing found her mid-trapezius muscle was weak, grade 4 paresis on the right side. Her medial deltoid was found weak on the right side, but this was on the second visit too. And the piriformis muscle was also weak on the right side. I also like to check that in the standing position, weight-bearing position. Methods. In the supine position, the patient's psoas muscles were assessed and found to be weak bilaterally. Dr. Zindler came up with this. Now, this is an anterior femur head. And also Dr. Victor Frank, for those of you who studied under him. Sacro-Occipital techniques, SOT arm fossa test was negative, so this means she's either a category 1 or a category 3. The radiologist's report described moderate spondylitic changes noted in the lumbar region with narrow disc space at the lumbosacral area. Various techniques were used to assess and treat this patient. Frank's total body modification was used to assess the inferior left occiput, which was adjusted using Dr. Tom Cates' method. Anybody in here from Tulsa? He's in Tulsa, Oklahoma. Goodhart's applied kinesiology muscle testing revealed weakness of the patient's trapezius muscle, which was treated with adjusting the patient's atlas vertebra. Also, Dr. Cates' method is very similar to Dr. Leander's adjustment, the way he does the occiput. Anybody studying under Dr. Leander Eckerd? Who in here has Leander tables? Nobody? I'm the only one. Various techniques were used to assess and treat the patient. Frank's stomach was used. Inferior left occiput was just, yeah, okay, we've already got through there. Okay. Zindler's method noted that a posterior C7 associated with ipsilateral weakness of the right deltoid muscle was followed, adjusted, and improved the strength of the right shoulder abductor. DeJarnette's method of adjusting an anterior thoracic with a dorsal block was performed to reduce the dysfunctional thoracic segments, just right out of his book. Goodhart's AK muscle testing revealed weakness of the patient's piriformis muscle associated with L5 rotation, which was treated, and muscle weakness was resolved in the side posture position. With the table board inserted under the pelvis, one pelvic block was placed under the left acetabulum at a 45-degree angle inferiorward, and the other block was placed pointed down. Now, you all notice the blocks are in just the opposite position as they should be, because this is for a right posterior ilium, and this lady had a left posterior ilium, so just reverse the blocks. Place pointed down at a 45-degree angle on the right anterior superior iliac spine. To facilitate the gravitational forces, leg weights were used, which is Veleo, V-A-L-E-O, and they were fastened end to end and they were placed crosswise over the pelvis to put pressure on the left ilium and the right ischial tuberosity. And this 40-pound weight was placed across left ilium, right ischium. Okay, the patient was left on the blocks for about 5 minutes. It doesn't take very long when you're using weights. It's not like gravity. When you're using weights, you can usually go to the next room and adjust the patient and then come back, take the weights off, and take them off the blocks. This was, also the patient was instructed to take some deep breaths and cough occasionally as you're supposed to while they're on the blocks. Following each office visit, it was noted that the base of the skull or the occipit lined up perpendicular with the long axis of the neck. All muscles would test strong, and leg lengths would remain even following the blocks after removal. By the 12th visit, 4th week, the patient reported having no pain or functional limitations. Chiropractic assessment still revealed some remaining left lateral flexion of the occipit and anterior thoracics at each office visit prior to the treatment. Following the 4 weeks, she was seen approximately 1 to 3 times a month, and since her symptoms and function are stabilizing, the goal is to sustain symmetry in position and function with monthly preventive care or wellness care, whichever you prefer to use. This case illustrates chiropractic integrative manipulative strategies and conservative care that appeared to successfully manage a patient presenting with chronic sacroiliac joint pain. She recovered full function and was pain-free following 12 office visits, and in that she did have a certain amount of sciatica. She did not require decompression. Further research is needed to study various integrative chiropractic methods in the treatment of patients with sacroiliac joint pain.
Did it like a professional. That's really good.